Today, I'm excited to be joined by Dr. Nora Fritz, a physical therapist and board-certified neurologic clinical specialist. She's an expert in postural control and falls in people with multiple sclerosis. We'll be diving into the latest research and sharing actionable takeaways you can start using right away. Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mauder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome, Nora.
Hi, JJ.
I'm so glad you're here. I really love reactive balance, so I can't be more excited. So, can you start us off by telling us a bit about your background and how you found yourself focusing on postural control and fall risk in people with MS?
Sure. I've been studying postural control and falls in individuals with neurodegenerative disease for over 15 years. It's hard to believe. Um, but more recently, we've been focusing on individuals who have MS. And I'm really excited about some of our most recent work where we've been studying backward walking as a indicator of kind of complex mobility and postural control. But today, we'll talk more about the reactive postural control side of things and what we've been investigating related to backward walking and reactive postural control.
This is like my jam. I love it so much. So I'm just so excited to hear about your research. And I'm really interested in why you think it's important to discuss reactive balance and, what questions as clinicians should we be asking?
Yeah, I think, well, one of the things I hear a lot from individuals who have MS is that they find that they're having these sort of near fall episodes where they're kind of tripping or stumbling. And so it makes you think, well, if you had the mechanism available to catch yourself, then maybe you could prevent a fall from happening. Now, I think we both know that that's not always going to be the case, that falls do happen. But having these kind of reactive mechanisms available in order to prevent maybe an injurious fall is what's really, I think, important. So we know this reactive balance is really critical for recovering from perturbations and for preventing falls. And so that's one of the reasons why I'm really interested in understanding more about it.
Yeah, I totally agree. And, you're right. We can't guarantee that we can prevent a fall, but the strategies that are involved, I always think of it as the high intensity of balance, getting to the reactive piece.
Right.
And I think that the NPT talks a lot about this, right?
They do, yeah. So actually, I teach in our neuroscience coursework and motor control coursework here at Wayne State University, and reactive balance is one of the 3 domains of balance that we learn about really early in the curriculum. It's one of the domains that ANPT focuses on, along with steady state and anticipatory control. But I do think that it's sometimes ignored a little bit, or at least a little bit less well characterized in the clinic. And I think that's mostly because the assessments that we have available, like our standardized balance assessments, kind of ignore reactive balance. So if we look at the ANPT's recommended balance outcomes for individuals with neurologic disorders, the FGA and the Berg Balance Scale are the recommended balance assessments, and neither one of them has reactive balance as part of it.
Right.
A lot of us probably use the Mini Best. It's a great tool, and it does have a reactive balance subsection. So that's one way we might be able to do that. But when I look at the literature as far as interventions for reactive balance, a lot of the protocols rely on kind of laboratory-based equipment. And I think that makes it hard to translate to the clinic.
Yeah, I remember first learning about this and I was trying to figure out how can we, and I still am to this day, trying to figure out how can we make more interventions
Yeah.
a reactive component. And then going back to the outcome measures, because you're right, the FGA and the Berg, gotta love the CPG from the
Yeah, it's great.
neuropt.org. So shout out to them. but and the mini best, I find a lot of clinicians are using that. But I think even just the reactive balance test within the mini best is challenging for them. They, just to do it correctly or to get the patient to be able to do it or to trust you to do it. I
Right.
mean, just starting with the assessment, it already is hard.
Oh, absolutely. And that's compounded by individuals who might have some cognitive decline, have difficulty understanding the instructions, or something that we care a lot about in my lab is if people are concerned about falling. So if they have this sort of anxiety or concern about falling, doing these sort of push and release sort of maneuvers and trusting that your therapist is going to catch you can be a very scary thing. We can talk about some ways that we try to overcome that in the lab, but, um, you know, assessing reactive balance is pretty critical if we plan to intervene on it in our goals.
And I've seen it where, if you didn't do that test, you would have missed the fact that they had limitations, right? They did really well with the other ones, but that is so specific. So,
Right.
and I don't think I caught. So you're teaching where you teach and do research. Where are you at?
I'm at Wayne State University. It's in Detroit, Michigan.
Okay. Okay. So
Mhm.
have you been there a long time? You said
Almost 10 years. Yeah.
okay, congratulations. That's a long time. But and I love to hear because you're in the midst of the research. So I'm really excited to hear that. So you're touching on some key ideas of assessment and intervention. So from your background, because I know because you research this, you really know the research. What stands out the most? Like what should we be taking away from what you know from the research?
Yeah. So, I've been looking at this a lot. We are running a trial right now that is comparing forward walking training to backward walking training in individuals with MS. And the primary outcome is reactive balance control. So, I don't so much care about whether people can walk backwards better than they could before. We think that's what will happen. But what we really care about is how that translates sort of to the real world and their ability to help hopefully catch themselves and prevent falls. So we've been doing, quite a bit of looking at the literature is related to reactive stepping. And one of the things I'm learning is that you can't really have a good discussion about reactive balance unless you also talk about sensory weighting. So this is that assignment of the relative importance of different kinds of sensory inputs like vision, vestibular, and proprioceptive during movement and balancing tasks. And what we know from data in healthy adults is that proprioceptive reweighting provides kind of a moderate explanation for the mechanism of reactive balance. And it suggests that you need both the ability to detect that there is a problem and to respond to that problem in order to have kind of an effective balance strategy or recovery strategy. So I'll give you like an example from our lab. Um, some of our patients who come in for studies really are vision dependent. They're very much relying on their vision for their balance. And when we ask them to walk backwards in the lab, they can't use vision to the same degree that they could when they're walking forward. So what should be happening is that there should be kind of a flexible reweighting of the importance of these different sensory inputs so that there's more reliance placed on the proprioceptive system or the vestibular system. And if the individual either is unable to do that flexible reweighting or if they have deficits in one of those other systems, we really see imbalances uh, come out in the lab. And so that could be, as we say, difficulty with the reweighting or difficulty with one of those other systems. And
I
we've been
think that
able.
can I just want to say that I just think we can emphasize this piece enough, and I'm sure you might be bringing it up again, but I don't want to lose my
No, you're
my
good.
eye here. Is that because the reweighting? So, you know, being able to switch based off the environment, which sensory system is going to provide you what you need.
Right.
Is that accurate? Okay,
Yeah.
so just recognizing to the therapist how important that is, right, to train that, to
Right.
provide different and variable environments so that we can help teach them to do that. But then we have to make sure we assess each system to know if one is more involved than the other. But just it sounds like just watching them walk backwards and not going well will at least put one higher.
Yeah, I think that's one way we can challenge the visual system without actually removing vision, right? So um, we often think about putting people in kind of a dim environment or a darker environment, like something that would be like walking to the restroom in the middle of the night or um, navigating on a walk outdoors in the twilight hours or something like that. But I think walking backwards just provides a different level of visual input. And so it's a situation where you would need to upregulate your proprioceptive system or your vestibular system. And we actually have a paper coming out in JNPT in July. It's online, but it'll be in the
Congratulations. That's
Thanks. Showing that backward walking challenges the proprioceptive system to a greater degree than forward walking in MS. So just sort of proving that point. And so I think that, when we think about reactive balance, we have to also think about, can people flexibly shift? Because potentially this reactive balance task is something that requires them to sort of upregulate other systems in order to accurately and quickly respond.
Yeah, and I think that's a big point that I hopefully you'll talk more about is the quick part. But that I like how you said that upregulate. So they have to upregulate the system to be able to provide them what they need. And you're right. Once they go into backward walking, they don't like that. And we don't walk around backwards all day.
No, we don't.
But
No.
it is a critical component.
We do take a lot of backward steps, though. So every time we sit down in a chair or open a door, we're taking backward steps. And we do know that a lot of falls happen in the backwards direction. So being able to kind of quickly step backwards in order to catch oneself would be potentially important.
Absolutely. Absolutely. So you're talking about the impairments and then the backward walking. So what else do you have within the literature that you've been looking at?
Yeah, so we've also sort of looked at what is the neural control of reactive balance, like where is this centered in the nervous system, and what kinds of tasks would really drive change in those brain areas. And what we see is that the neural control of reactive balance is largely centered in the brainstem and the cerebellum, and I don't think anyone will be surprised to hear that, particularly given the timing element. But what's really interesting is that there is some recent evidence to suggest that there's some cortical involvement, and that might be for sensory processing of unexpected perturbations, what we've just been talking about, but also for error detection of the expected as compared to the actual postural state, and then some of the planning and execution for those compensatory stepping strategies. And one of the things I think we're also really interested in is the impact of the cortical involvement as it relates to concern about falling. So, how someone actually will respond to a reactive balance um, assessment in the clinic might depend on how concerned they are about actually falling, right? And so that's one of the things we've been looking at. We've also looked quite a bit at the training studies that have been available. So there are some training studies that have incorporated reactive stepping in individuals with MS, and they've been able to show that individuals can improve their reactive balance control with training, which is great. And what they see is shorter latencies, so shorter postural latency responses. So the time it takes them to actually initiate the step and take the step gets shorter, which is good. And that they change the length of the step that they take for the reactive stepping. There's improvements in timed up and go, in 10-meter walk test, in Berg, in ABC scores, and in prospective fall risk after doing this kind of um, reactive stepping intervention.
So because I've done some research in that area, and it always amazes me, and it's like so exciting how well they respond to it. And can we go back to you were talking about the brainstem and cerebellum, and then cortical areas,
Yeah.
and then I start just listening to you talk. I know this sounds rather basic, but I'm thinking that's a lot of places to go for some really quick info. I mean, you need to
Yeah.
do this quickly. You need to be able to identify the area and, recognize it and go. And I know that's what balance is all about, but I don't know. For some reason, the backward part, because like you said, you don't just need the input, you need the output.
That's
So I
right.
always thought of it as retraining like the stepping to make the the recruitment quicker. But do you think there's something about just the practice of getting the message and then being able to detect that as well?
I mean, I think so. So I suspect that, you would want to train all parts of the system if you can. So physical therapists are experts in identifying these kinds of movement dysfunctions and seeing, is it a recruitment problem? Is there a strength issue or a force production problem? Is it a overall balance issue, like a postural control? There's reduced strength in the trunk? Is it a coordination problem? Like, where are the issues? And it could be in more than one spot. So certainly in individuals who have MS, they could have lesions that are impacting not only like the transmission of the signal through the spinal cord, but maybe they also have lesions that are impacting their vestibular control as well. So there might be things in multiple parts of the system, and we get to put on our detective hats and try to figure out how we design an intervention that is really task specific and targets those brain areas, which is kind of cool.
Well, it's one of my favorite things, right? We need to be able to problem solve and say, okay, but I really appreciate you bringing up so many different areas, because that's why we need PT and OT, right? We need
Absolutely.
both components of the team because everyone's eyes are on balance. I always say, if you want to go for the biggest heavy hitter, it needs to be keeping them off the floor and balance. And so between both PT and OT and all the functional activities, like where and how are they losing their balance in what situations. So you had mentioned we may need to go to postural control and giving them more proximal stability, especially when we're thinking, I'm not especially, I shouldn't ever say that in neuro, but I think with people with MS, I always picture, lacking proximal stability, but we don't know if they have the range to step backwards.
Right.
Yeah. Or do they have the strength versus the speed versus detecting? And again, I agree, we're looking at multiple things, but I think what I really liked about you just gave us a really nice list of things to consider and to remind both disciplines, I think, to keep your eyes open so that we can together figure out what would be the best way to design the interventions, which I know we'll talk more about. But just, I get so excited because to me, that is it's problem solving, detecting, trying to go through and saying, and then testing and then saying, oh, nope, I guess it wasn't that. Move
Right.
on. What's the
Right.
next thing?
What's next? Yeah, exactly.
All right. Let's talk about this in regards to practice. So are there particular types? I know we were talking about patients with MS, but have you, in your background and your experience with the research, have you seen other diagnoses that are particularly appropriate for using reactive balance?
Yeah, absolutely. So we've been talking mostly about MS today because that's a lot of what my lab does, but I've done a lot of work in other degenerative diseases as well as older adults. And we know that there are reactive balance studies in Parkinson's, in stroke, and in older adults. And so it's likely that this sort of standing reactive balance training would be appropriate for almost any ambulatory individual, regardless of their diagnoses. Of course, there's also reactive balance training in sitting, which could be appropriate for individuals who may be at a lower level of functioning or might be primarily a wheelchair user, and that would be super important. The FIST, for instance, function sitting test does incorporate reactive balance elements that are quite useful for assessing that.
Yeah, I just want to emphasize that one because if you're not familiar with the function and sitting test, so you can, Google function and sitting test and you'll find a great website. It's Sharon Gorman, I think,
Mhm.
who's done that research and just the test itself and shows the videos of it. And just because I think it's really important to say it's not just about reactive, what you just said in
Yeah.
standing, it's about it in sitting and people being able to take anything and stay off the floor, right? So,
Well, the other thing we haven't talked about at all is the idea of reactive balance during walking or during stepping, right? So all
good
of
point.
all of our assessments are in static, like in standing or in sitting. And, as we know, a lot of our falls and things don't really happen when we're standing still. It's usually while we're moving. And so being able to sort of look at that in our clients and then assess or provide interventions that challenge that, it is a challenge, but it's certainly something we have to do to get the largest gains, I think.
And no pressure, Nora, but I think you should put on your list of things to do to figure out an assessment tool for reactive balance when moving. Okay, just add that to your list there.
Note to self. Okay.
So,
There
okay,
is some pretty cool work that's being done at a lab in Australia where they have like a specialized walkway where people walk across and it will flip up little things that they trip on as they're walking, or it will slide and they'll slip on the floor as they're walking. And so I think that's pretty nifty, but I'm not sure that that's going to be possible in every lab around the world, So maybe we'll
well,
do
I wanted to transfer out like to the therapist. Like, relax,
exactly.
no pressure, no pressure.
Right.
I,
Okay.
you can figure-
There's
all
some
right, so
hands and you just pull on them. No, I'm kidding.
hey, we might get somewhere with that. You don't know. So, okay. So now you brought up some examination and you brought up some intervention. So like, can you give us some more examples of like how this might show up in an actual therapy session for our clinicians out there? So I really want them to feel more confident or at least have more ideas to start increasing their confidence because
Sure.
our confidence really impacts our patient's confidence, right?
Yeah, absolutely. So if we start with the assessment piece, we use the reactive balance section of the mini best, but we also use another tool that was developed by the same group. This is Faye Horak's group out in Oregon. And it's just called the push and release clinical scale or clinical score. She's got a nice paper that they came out in 2006. And I like this scale because it is very similar in setup to the mini best. However, the ratings that you get, there's a larger scale than you see in the mini best. So there's more levels from which you can rate the participant and how they actually did the test. And so I like that because I feel like you can see change a little bit easier than you can on the mini best. So I recommend checking that one out.
No, okay, I'm sorry. So I'm gonna tell us just a little. I mean, I feel really. I haven't. I've heard of it a couple times, really recently, and I haven't like explored that more or been reinforcing doing it. Can you just like describe it real quick? Like, what
Yeah,
is?
yeah, it's just like the mini best so we use it for the backward direction specifically because that's what we're studying in the lab. But essentially, you have the person lean back into your hands and you kind of hold them there for a random amount of time, but no more than 5 seconds probably. And then you let go, and their job is to catch themselves, right? So to do whatever they need to do to catch themselves. Um, and the rating scale has some different things like, did they take one large step, multiple small steps? Did they even initiate the lean back or were they like unable to lean? Like there's a whole bunch of different things that you can kind of rate them on, which I really like. And so that's sort of how that goes. And I will say that we definitely have people who come into the lab who are not willing to do this. Like they do not want to do this. Or what will often happen is they'll just sort of extend back without bringing their weight backwards, right? If that makes sense. So they're not actually putting any weight into your hands. And so what we found has been pretty successful is that we will demonstrate what this looks like. So one of us in the lab will actually do the lean and release and show them how far back do you have to lean. Um, and we'll demonstrate that, yes, we absolutely can keep you safe. We will catch you. We will not let you fall. And sometimes we have to use sort of manual cues. So we'll give the verbal cue that you want your shoulders and your hips to move together when you do the lean, right? So it's the like kind of like a trust fall almost. And then even if that doesn't work, we might give a sort of a manual cue at the hips to kind of get the person to lean back. And when we're doing this for research, we have them do it 5 times. So the first couple times are for practice and also so that we don't get that kind of startle reflex. And then the last 3 are really for measurement. And so, they get a chance to sort of feel what it feels like. And we've been pretty successful with getting people to do that. So
Okay, I have follow-up questions.
that's okay.
It sounds like, I mean, it's called the push and release, but it
It's really a
sounds,
lean and release.
I was
Yeah,
gonna say, okay, I wanted to clarify the push because it was like,
not
okay,
really a push. Yeah.
you're leaning outside base of support. So is it exactly the same as the backward component of
Yes.
reactive
Yes.
compensatory stepping? It's just that the scale is different. And that
Correct.
scale sounds amazing because you're right to describe that they won't let them step, or bigger step versus smaller step. I love that. So now you gave me homework. So thank you for that. But they still have to lean outside their base of support, and right, the instructions have to be clear that do whatever it takes, including taking a step, like you want to give them that permission.
Yes, absolutely.
Okay. And so my other follow-up question was, so you're doing it 5 times. Have you ever noticed, do they improve? Like, do they learn within that time of doing? I know that's only a couple of times, but
Sometimes I think, yes, that's the case. We do kind of randomize the amount of time that we hold them in that position so they
Mhm. Yeah,
can't anticipate the release. Or, I mean, they know it's coming, certainly, but they
right.
won't anticipate exactly when you're going to do it. Typically, people perform pretty similarly on trials 2 through 5, I would say. So the first trial might be different because they're never done it before, but then trials 2 through 5 tend to be a little bit better. And I think what's really exciting for us, we haven't formally analyzed the data from our ongoing trial yet, but what we can see with our eyes is that people seem to be getting better at doing this task from pre to post training. And so that's pretty exciting to see.
It really, it's truly amazing. And I thought there was one other thing I was going to ask you about that test. Um, just because, I know, because I remember learning from Faye Horak, that if they won't do it at all, you really are assessing if they can take a step. And that's when you can do, and you didn't say it like this, so I want to make sure I'm thinking this right. You can do a quick pull at the waist when they're not expecting it. That would force them to take a step back. Is that accurate?
Yeah, so that's a different kind of assessment in my mind, but I think that's absolutely true. So if they will not lean, you could do like a pull test, yeah, a retropulsion pull test, or which is part of like the Huntington's disease rating scale, the Parkinson's disease rating scale, um, and a few others. So this is, yeah, like a pull either at the shoulders or at the hips, right? A little bit different than like the sternal nudge that we see in the Tenetti, for instance. But yes, you could absolutely do that if you were looking to get, at least in the clinic, some assessment of their ability to even generate a step.
Were you talking about something different then when you gave the example that if nothing else worked, we would
Oh, we will just
different?
cue them to lean back into our hands by cueing at their hips. So we'll still do the same test. We just kind of cue them to move their weight backwards, if that
Okay.
makes sense.
Are you putting your hands on or do you move your hands
On their
down?
scapula, yeah, on their shoulder
Okay.
blades.
So you
Mhm.
stay there. Do you ever adjust if they're not staying straight?
No, we don't. We
Research.
try I mean, for research, we're trying to
Yes.
standardize it, of course. In the clinic, you certainly could make those adjustments. I would say that to do it the same way, at baseline and at, reassessment, though.
Okay, so to document. This is why Nora, I don't do a lot of research because I don't like to follow the rules. Because I'm like, but that person doesn't need that. We need to adjust it. And then it's like, Jen, knock it off. So okay, so yes. But for clinicians, if you were to find that this person just totally does not want to do that, you could adjust your hand placement, document it, and then just be consistent. Would you agree with
Absolutely.
that? Okay. Okay. All
Absolutely.
right. Sorry. I get very excited.
No, it's
I mean,
good.
I think it's just so amazing when you see the changes that, um, you really want to show them. It has to be so scary for them because just a trust fall in general is scary when all your senses and everything is working well and you haven't fallen and you're not scared of falling. And then you put all of that together and it makes a big difference. Have you found ways to get like the patient and the caregiver to like buy into all this?
Yeah, so we will explain why we're doing it always. So we always tell them, like, this is the primary outcome of the study. This is what we hope will get better with this study, right? And this is why that's important. So we give them a why, certainly. I think as a clinician, it might be really important to actually assess someone's balance confidence and their concern about falling before you do this kind of a test. And that could be with a formal assessment like an ABC or a FESI, or if you want to try out our new scale that's called the CAFE, which is the concern and fear of falling evaluation. It incorporates both concern and fear on a continuum, where the FESI just has concern. So
This is the falls efficacy scale. What's that
international.
for? International. Okay,
Yeah.
just
Yeah. So, kind of getting a sense of where that person is at baseline can be helpful. Sometimes we have people who sort of overestimate their ability, right? And other people who underestimate their ability, but it at least gives you a sense of where they're starting. And then you can explain to them why you're doing this, because it can be scary. And you can explain to their care partners, if they're there, why you're doing it, why interventions that target this are so important, particularly as they relate to things like falls and home functioning and community participation.
oh, yeah, I love that because you want them to be safe. Everybody wants them to be safe. So, maybe you could the cafe, what was it? The concern and fear of falling evaluation?
Evaluation. Hmm.
Is
Yeah.
that anything that's been published yet that you could, like, share in the
Yeah.
notes?
So we have published both the scale development and the validity of this measure. And actually, this is work led by a doctoral student in my lab. And she recently recorded a podcast for the Neuro section of APTA about this measure. And
Oh,
so
okay.
you can check that out too if you like a podcast. But I think it came out in December of
Okay.
2024. So yeah, they're both published. Mhm.
No, because that sounds great because I love those. And but then oh, okay, ABC is part of the CPG. What would you say to if I was trying to choose with for the cafe? Is there anything that stands out just quickly in regards to that's different?
From the ABC?
Yeah.
Oh, so they're two different constructs. So ABC is balance confidence, and the cafe is about concern or fear for falling specifically. So just two separate constructs. But what we do have a new study actually that just came out recently where we show that better reactive stepping performance is related to fewer concerns about falling, greater confidence, so balance confidence, and also lower feared consequences related to falls in individuals with MS. So, this idea of being able to potentially improve someone's balance confidence improve their reactive stepping might improve their balance confidence or some of these other measures. That's something that we'll certainly be looking at. But I think there is sort of a tie with these different things.
Would you then do the ABC and the cafe if
Yeah,
we're
you
looking
could.
at
I mean, yeah, if you want to look at both constructs.
if
Mhm.
we're okay doing that component? I just think it's interesting because I just remember sometimes people would, like you said, say I'm perfectly fine, and then after they you do this and they're like, "Oh, Nelly, like, I fell backwards a couple times." Then all of a sudden their fear went up. But
Yes.
and then that comes the intervention part, like, the training part. So, like, do you have suggestions of so you find out that they score low on the cafe, they they push and release, they do not do well on, and they're definitely at risk from an intervention standpoint, which do you have suggestions?
Yeah, so I think this is kind of new territory, right? We're trying to figure out what is the best way to intervene in these situations, and do individuals with more concern or fear need different kinds of intervention? So I'm not sure we have an answer to that just yet. But I think if it was my patient and I was the clinician, I'd be thinking like, okay, well, we certainly need to work on reactive stepping. So I need to put this person in an environment where they at least feel they can attempt reactive stepping with some measure of safety. So if you have like a treadmill with a harness on it, maybe we start there and we do some walking and we provide some perturbations, or we provide some kind of obstacles or things that might trip them up that we could attempt this. I don't know that I would go straight to open hallway walking in this person who's feeling really really concerned about their falling. Um, you could also ask them, what kinds of environments do they have at home, and we can try to mimic that in the clinic and see if we can reproduce parts of their life that feel concerning to them, or where they feel less stable. Um, I will say, when I was a doctoral student, we did a balance intervention as part of my thesis, and in general, the group, these were individuals with MS, got worse on the ABC after the balance intervention, despite their balance getting better. And so that speaks exactly to what you're talking about. It's almost like a recalibration of their baseline confidence about their balance. And so there's work to be done, I think, in both the motor domains and potentially in the kind of psychological domains that could be the future of this kind of therapy.
And I agree. And I think you bring up an excellent point. Like, start with what's their life like? Like, do they have big dogs that will hit them and they have to step back to regain? Because then it makes sense to them. And it's not just, oh, I'm walking backwards or I'm stepping backwards just because this therapist told me. It
Right.
makes sense. And then do your best to figure out, okay, how could I mimic that context? Maybe I put them in a corner, but you roll the ball hard at them, one of the big balls, so that it hits them like the
Mm-hmm.
dog would. Or, I think we just need to keep being creative. Sometimes I'll take the bungee around the ankle just to give them that feel of stepping back. If they tighten it and then loosen it, it pulls them back quick so they can
Right.
feel it. But then it's tough because, when you start doing some reactive, my students thought of a really good one where they're having them walk, because I'm always like, airports. Airports are the best place ever because it start, stop, looking, people moving, and they were doing like the pool noodle in front of them to really quick. So then all of a sudden they had a quick stop and
Mm-hmm.
then go and then quick stop. And I think, but then you do that a couple times and then they figure it out and now it's anticipatory. So
Right.
we need so many more ideas. We need like the 99 best and, reactive interventions. And so
Well, I
I
always
love the
joke.
setup that you have in regards to the assessment. I can't wait to look at the cafe because I just think then that helps give us more intervention ideas.
I always joke with my students that, like, well, not necessarily a joke, it's true, but any anticipatory task can become reactive if you lose your balance, right? So we talk about, layering on the complexity of the task. So you start them in one place and you're right, they becomes more anticipatory. They start to figure it out. That's when you have to progress them, right? Now we got to try something different so that it is more challenging. And then when you add that complexity, then you're reassessing, okay, how's their reactive balance under this situation? What about when they're reaching? What about when the target is really far outside of their base of support? What about this? What about that? So I think you're right. This is our constant challenge to kind of layer, make it more and more challenging.
Yeah, and trying to make it in the clinic. Like you said, the tests are standing and we don't have these pathways with things
Right.
popping up. And
Right.
so now we're trying to mimic some of these things. I think of, like you're trying to open the car door and no one's unlocked it yet. And then you keep pulling, and then suddenly they unlock it. And so now you step backwards. Like, can you mimic giving strong resistance with quick releases or, use the bungees, use the TheraBands? Well, that's kind of my
Yeah, you
MO.
could
But
probably do that with a door too. If someone's on the other side holding it closed and then you let go, right? That would be a good one.
actually, I was holding the door open in a hotel room for my friend and, like, leaning against it, but
Mhm.
then she went and pulled it open, and I didn't realize she was she was gonna do that, and I was like, "Oh my gosh, there's the best reactive balance idea ever." I was very excited, so it's like, I gotta figure out how to make that repeat that, so
That probably does bring up a good point, which is when you're trying reactive balance interventions in the clinic, it might be helpful to have a second set of hands with
yeah,
you.
and a gate bell and a corner and yeah.
Some foam pads on the floor.
Yeah. So, all right. So I'm sorry. I just get very excited. So if you're thinking, I want to hear about what you think about making the biggest impact. What we like to do on MedBridge, we like to do the top 3 takeaways that clinicians could put into practice right away. Well, what say you, Nora?
I think I would say to first be sure you're assessing reactive balance separately from anticipatory and steady state control. So we talked about that today. Consider some of those psychological factors that might impact reactive balance, like concern about falling. And that when you're designing interventions to really target reactive control, be sure to challenge it both in standing and during walking and transitional movements, if that's appropriate for your client.
Yeah, that's the kicker, right? Is those postural transitions. Okay, so that's really helpful. So What about from your research or your clinical experience? I know we've already talked about some, but are there other ones that would help bring to life like these aspects that you have brought up that I just love so much?
I mean, I think we've touched on a lot of it, but I will share just a case example. We have a case series that's under review right now, and will hopefully be published. It was sort of the pilot data that provided evidence for our ongoing backward walking trial. But in this trial, what we learned was that there were several individuals who were actually just unable to initiate a step when we did our push and release protocol. So they would lean back, they would do the whole thing, but they couldn't actually initiate a step. So it would kind of be a lean and then they would just sort of keep going. So we would catch them, they were safe, but on 5 trials, the same thing, could not initiate a step. So, as we mentioned earlier, you got to put your detective hat on. What is going on here? But we use sensors to pick up the movement, and the sensors don't record anything if you don't initiate a step. But what we found, which was like really exciting, is that after 8 weeks of this backward walking intervention, they could initiate a step. So even though we couldn't calculate like a between difference from pre to post with our sensors, this is obviously clinically meaningful, right? To be able to now take a step on this reactive balance test. So that was like really exciting for me. I thought that was like one of the coolest findings, that we had these 2 individuals who could not initiate, could after 8 weeks. So we're really excited about that. And I think that's partly why I really love this clinical scale that we talked about earlier, because now I can show that on this clinical scale. They weren't initiating, now they are. This is a definite improvement. So I think that would be the little case example that I would give is, to encourage your clients, like, even if you're not successful at this initially, this is something we can improve, and we're going to get better at it.
Well, and that's even better sometimes. I mean, sometimes we're scared to do tests that they're going to do badly on. And I'm always like, embrace the zero, like embrace it
Right.
and tell them now all we have is up, and now we know what to really focus on. That could make the biggest impact. And I think sometimes our excitement can make a big difference with that. I want to ask, do you think you can, do you have a link for the push and release test that we could put in the show notes, or we
I
can look
can,
that up
yeah,
later, but
and I did put the citation for it.
okay, perfect. That's all we need. I
Mhm.
just wanna make sure people know where they could find that. Um, and I was gonna ask one other thing about that, and now I'm blanking in regards to the backwards I know. For your study, and I don't know if you can tell us, it might be super secret, 'cause but, I never know for the research component or where you're at with research, but can you talk about it all? And you can say no, what your intervention for the backward walking, your study
Oh,
is?
yeah, absolutely. So our protocol paper has been published. So we have
Okay. Oh,
a
good.
full protocol paper you can read if you need some light bedtime reading.
Sure.
And yes, it is. This is a randomized trial. So people get either a forward walking intervention or a backward walking intervention delivered by a physical therapist. And the training involves 1 day a week in the lab and then 2 days of work at home. So the in-lab component is both treadmill walking and overground walking, and then it's combined with functional exercises that incorporate either forward stepping or backward stepping. So both groups get exactly the same thing, it's just the direction that's different. And
Oh,
then, if that makes sense. And then at home, they do some walking, overground walking in whichever direction, and then the functional exercises, which change over the 8 weeks. So they get some progressively more challenging exercises over the course of the 8 weeks.
and these were people with MS or
Yes. So in this trial, it is individuals with MS of all subtypes. They have to have either 2 falls in the last 6 months or self reported difficulty with walking using the MS walking scale 12, which is a self report measure of walking disability.
and if they needed help on the treadmill, were you able to help assist them?
So we put them in a safety harness, but there is no body weight support. So in order to be eligible for the trial, the individuals have to be able to walk without physical assist for like about 5 minutes at a time. So some clients did experience some level of fatigue, of course, or challenges. Some days, were better than others. And so in the several cases, we did have therapists assisting with a limb during the walking, but I would say the vast majority are able to do it unassisted.
Okay. And
Mm.
just curious now, because this whole transfer and getting people to do things at home and the importance of
Yeah.
the carryover so we can see them progress without having to need us per se. Did you have any issues with the backward walking group doing things on their own?
So we haven't specifically evaluated that, but at least anecdotally, no. So we fit everyone with a Fitbit for the whole trial. And our therapists do Zoom calls throughout the training at home. So it's like kind of a faded feedback schedule for the Zoom calls, but they'll actually have the person do the walking while they're on the line with them. And we'll look at heart rates from the Fitbit to kind of see if we're matching the intensity at home that we're getting in the lab, as far as how hard they're working. So we tell people we want them to be kind of between like a 3 and a 5 on a 10-point Borg scale. So they're working like, somewhat hard to hard during the walking. And so it's been working pretty well. I think the first week it's mostly about finding or problem solving where in the house they're going to do this or where outside they're going to do this safely. But people have been incredibly creative. So it's been great.
I think that's its own study right there. Just that, just that tech part of zooming with to get carryover from an exercise program, and what challenges did you run into in regards to the tech issues, or the Fitbit and how much it costs, and how long did the session take, or could you do short sessions so therapists could see
Yeah.
multiple people in an hour to check
Mhm.
in with them and make sure that they're doing things, and seeing that we can get carryover and figure out how could they do it in their house and
Yeah.
find a safe space. I think not not that you didn't already think of that, but I think that's a great research project, especially
That's a good paper to write up.
given the times, since you
Yeah,
have nothing else to do.
some people have been going to, have been using treadmills at home if they have that. Some people are walking outside. And in fact, one of the patients was telling us that she's now convinced like other people in her neighborhood to do this with her because they've been stopping her to be like, what are you doing? Um, and then we hear about people going to gyms to do it on treadmills there and seeing other people join them and back, which I think is amazing. I think this is fantastic. Um, and
I
some of our clients in the forward group will go to kind of like a big box store, like a Target or something, and they'll walk like the perimeter for their walking, if the weather's bad, outside, things like that. So lots of really creative options.
Well, and just that right there. See, I get so excited. Just providing that list of options so therapists have a list of things that they have found people have already figured out that help or that were possible. And so that, because we just need to present ideas, because sometimes when you're really stuck and you don't think you can do any of those things, you don't even know where to start. So you could even like list them as a progression. So we'll leave that to our audience to work on and get us a list and get back to us, because
That
I
sounds
just think
great.
that's a really great idea. All right, Nora. So I mean, you're getting the feel for me. You know me just a little bit, but I wanted something fun at the end. So before we wrap up, I've got one light question, kind of fun for you. If you could have any superpower, what would it be?
Yeah, I'm really happy you asked me this ahead of time because I had to think about it for a while. I think there's lots of good choices here, but I'm going to go for a more unconventional one. Um, I have two small children, and they are both really into the movie Encanto, especially the songs from the movie Encanto. And there is a character who heals people by making them food, like heals them with her.
Right, I remember that.
Yeah, and I think that would be pretty great. So I'll choose
You
that.
like to cook?
I do like to cook. Yeah.
Okay, so the combination of healing and cooking is
Yeah.
right up your alley. I love that. That's a great answer. Okay, I'm very impressed. I'm very impressed. I didn't think I could be more, but I am now. So all right, Nora. Well, that's all the time we have for today. So just a huge thanks to you, Nora, for sharing such great insight and practical takeaways on reactive postural control. I hope this episode gave you a few new things to think about and maybe try out in your own practice. Can't thank you enough, Nora.
Thank you so much for the invite.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.